Recurrent miscarriages case scenario is the topic of our discussion today. Patient came to OPD at 8 weeks of pregnancy. She presented with mild PV spotting. She had one preterm at 33 weeks because of preeclampsia and one abortion. How would you manage her? First of all, take detailed history from the patient, like name of the patient, age of the patient, because advanced maternal and paternal age of more than 40 is a risk factor of recurrent miscarriages. Ask about the marital status, especially consanguineous marriage, and the duration of marriage, education, occupation, the parity. Ask about previous miscarriages because it is a risk factor for recurrent miscarriages. Ask about LMP and cycle regularity. Regarding the current pregnancy, ask the questions like whether it was planned or unplanned pregnancy, whether it was spontaneous or she conceived with medication, did she take any folic acid or not, if yes, how much was the amount, was any dating scan done or not, and did that show single or multiple pregnancy. Take detailed history about presenting complaint, like as she has presented with the vaginal bleeding. So ask about its onset, was it spontaneous or gradual, ask about its severity and the amount, and is this her first visit or she visited before, and any passage of grapes like vesicle, which may indicate the molar, was it provoked after coital activity or was it unprovoked, associated vaginal discharge and associated pain. By keeping the differential diagnosis of recurrent miscarriages, ask certain questions like the previous or family history of miscarriages for chromosomal causes. Ask about any previous scan showing uterine anomaly. Ask about history of the weight gain and hirsutism to rule out PCOD. For thrombophilia, ask about the leg swelling and pain and clot formation in the body. And for APLS, ask about the history of any raised blood pressure, leg swelling, clot formation in the body, anticoagulant or injection use, and the bleeding gum or nose bleeding or the bruises anywhere in the body. For SLE, ask about the joint pain, fever, and rash. And for the diabetes, ask about any history of polyuria and polyphagia. For thyroid illnesses, ask about any history of heat and cold intolerance. And for placental abruption, ask about painful PV bleeding. And for painless PV bleeding and history of painless pregnancy loss, by asking these questions, we can rule out the cervical incompetency. For Asherman syndrome, ask about repeated DNCs. For hyperprolactinemia, ask about milky discharge from the breast. And vaginal discharge indicate STIs. For fibroid uterus, ask about heavy menstrual bleeding. And if all these causes are not present, she might have an unexplained cause of recurrent miscarriages. Take the detailed obstetric history, like previous history of the miscarriages, mode of the previous deliveries, any antenatal, intrapartum, and postnatal complications, what were the sizes of the baby, any instrumentation done, was it prolonged labor or of normal duration, any episiotomy done or not. Take the gynecological history, including the cervical screening. Take the medical and the surgical history, the personal history of the smoking, the drug abuse, alcohol, and caffeine, which are also the risk factors for recurrent miscarriages. Take family history, the drug history and drug allergy, any investigations done so far, what management has been done so far, has she been on aspirin or heparin or not. Then in the examination of the patient, do general physical examination including BMI if it is less than 19 or more than 25 kg per meter square. These are the risk factors. BP is raised, and that is also a risk factor for preeclampsia. In systemic examination, we do the breast at the chest examination. On per-abdominal examination, do inspection for any scar marks, visible pulsation, palpation for any mass in the lower abdomen or visceromegaly. Sterile per-speculum examination is done for the health of the vagina and cervix and for any pathological vaginal discharge. If that is present, then we have to take per-speculum. We have to do the per-speculum examination and take sample if it is due. Do bimanual examination for size, position, and mobility of the uterus, and any adnexal pathology. Then we do investigations, which include the baseline health profile like blood group and RH factor, blood complete picture including hemoglobin, total leukocyte count and platelet count, midstream urine analysis including nitrites, pus cells, proteinuria and glycosuria, blood sugar random, HbS antigen plus anti-HCV plus anti-HIV antibody, then cytogenetic analysis of the product of conception of the previous miscarriage, and if that is abnormal or if we have unbalanced translocation, we have to go for the parental karyotype, and if that is abnormal again, then we have to refer to clinical geneticist. We do the thrombophilia screening for protein S deficiency, protein C deficiency, antithrombin 3 deficiency, prothrombin G mutation, and factor V Leiden deficiency. APS screening is done for lupus anticoagulant, anticardiolipin antibody, anti-beta-2 glycoprotein 1 antibody. APTD testing is done if patient is on heparin injection. Transvaginal scan is done for uterine anomalies, and if any abnormality of the uterus is there, then we have to notify that. Also, we have to check that endometrial thickness, endometrial myometrial ecotexture, and adnexal pathology. If uterine abnormalities are suspected, we have to consider 2D and 3D ultrasound or laparoscopy or hysteroscopy. Then comes the management. We should have sympathetic approach toward the patient and will empathetically consult the patient. We have to debrief the patient regarding diagnosis, its implication, and plan of management. If any cause is found, then we will explain. If not, we will tell the patient that most likely it is unexplained, which occurs in 25% of the cases. We have to involve the multidisciplinary team, advise bed rest and pelvic rest. That is, we have to tell her that she has to avoid intercourse and heavy work. Then avoid vaginal examination until ultrasound confirms intrauterine pregnancy. Anti-D immunoglobulin is given, that is 50 microgram IM if Rh negative and less than 12 weeks of gestation, and treat any infection if it is present. We have to provide the supportive and medical care to the patients, which include folic acid 400 microgram daily. Progesterone support empirically if luteal phase deficiency or threatened abortion risk is there. For example, dydrogesterone 10 mg BD or micronized progesterone 200 mg vaginally. We have to monitor the symptoms. If bleeding increases or pain develop, reassess urgently. We have also different combinations of progesterone. Oral route progesterones include the Duford or Dufeston, which include dydrogesterone. The vaginal preparations include micronized progesterone like cyclogest and fertigest. The intramuscular preparation include the Proluton depot. Then after that, we have to do the follow-up and long-term management, which include repeat ultrasound after 1 to 2 weeks to confirm fetal viability, and monitor BP regularly during pregnancy due to history of the preeclampsia. Start low-dose aspirin, that is 75 to 150 mg per day at 12 weeks to prevent the recurrence of preeclampsia till 36 weeks. Advise antenatal visits frequent and high-risk follow-up. Screen for proteinuria and fetal growth restriction later in the pregnancy. Then appropriate patient counseling is done. We have to explain the nature and prognosis of threatened abortion, reassure that with a normal scan, most pregnancies continue successfully, educate about the warning signs like increased bleeding, severe pain, dizziness or fainting, advise early booking and regular antenatal care, and discuss the recurrence risk of preeclampsia and its preventions, including aspirin and calcium. So that was all about the case scenario of recurrent miscarriages. Subscribe on Obs and Gynae and follow the Facebook page of on Obs and Gynae.